Now, today we'll be talking about metabolic acidemia. Now, what is metabolic acidemia? We know whenever we do ABG or VBG, we see the pH of the blood. The pH of the blood is in between 7.35 to 7.345, which is a normal pH. Now, whenever this pH is less than 7.35, we call it as we have an acidemia in the blood or increased acid in the blood. So it is always whenever we call it as metabolic acidemia, we are referring that the bicarbonate is less than normal. Whenever we call it as a respiratory acidemia, we are referring that the PCO2 in the ABG or EVBG is more than normal. Normal PCO2 is 35 to 45. So if it is more than 45 and if the pH is less, then we call it as a respiratory acidemia. So when pH is less than 73.35 and bicarb is less than 22, we refer it as metabolic acidemia. So if pH is between 7.20 to 7.35, we can still label it as mild metabolic acidemia. When it is less than 7.2 and it is up to 7, we call it as moderate acidemia. And when it is less than 7, we call it as that patient has severe metabolic acidemia. Patients with severe metabolic acidemia can die at any point of time. At any point of time. So acidemia has to be corrected very, very vigilantly. So normal bicarb is between 22 to 26. Whenever there is metabolic acidemia, this bicarb falls less than 22. More severe is the metabolic acidemia, lesser will be the value of bicarb. It can be 4, 5, 6, 7, 8, 9, 10. So lesser is the number, severe is the metabolic acidemia. This acidemia is very bad because it can be life-threatening, especially if the pH is less than 7.2. Patients can have cardiac arrest at any point of time. The second reason why metabolic acidemia is bad is it is very commonly associated with hypotension. It is extremely, extremely common to have hypotension, especially in metabolic acidemia. Many of the patients, even if the patient has acidemia and blood pressure is normal, you should very vigilantly keep on checking the blood pressure every 20 to 30 minutes because blood pressure definitely usually drops always, and that is because of the arteriolar dilatation. And hypotension is the reason why the MODS or multi-organ dysfunction comes into the picture because acidemia causes hypotension. Hypotension reduces blood flow to each and every organ, each and every system of the body, which causes then anaerobic metabolism, which again increases the lactic acidemia, which again increases the metabolic acidemia, and which again increases the hypotension. So this is all vicious cycle. Metabolic acidemia begets hypotension, hypotension begets the metabolic acidemia. So underlying problem has to be corrected. The third, the third problem is tachypnea. Now, why is tachypnea? Why tachypnea occurs in metabolic acidemia is because there has to have some respiratory compensation. Whenever bicarb is less than 22, pH is less than 7.35, we label it as metabolic acidemia. So, by increasing RR, we simply do carbon dioxide washout. So when we know that CO2 plus H2O, these two mix and form this bicarbonic acid. We know that H plus is already very much in the blood. That is the reason why there is metabolic acidemia. So if you want to flush out this metabolic component, this H plus component, we must use this bicarbonate plus H plus to create this water and CO2, and this water is then retained but the CO2 is flushed out. That is how you reduce this H plus, you reduce the metabolic component. Tachycardia is one of the very important and very bad factor for metabolic acidemia because in acidemia this hypotension is common, tachypnea is common, and to keep all the system in loop, to keep all the systems like kidneys, brain, everything, to maintain the sufficient cardiac output, to maintain the sufficient blood volume, tissue perfusion to all these organs, tachycardia is always there. So it's very important to always see this tachycardia. Very commonly, the tachycardia can be because of either dehydration or hypotension. If it is because of dehydration, it will respond to IV hydration excellently. This dehydration can be uh, seen by presence of skin turgor or tongue dryness. If tongue is dry, skin is dry, we can simply see IVC. IVC is best parameter. Normally, IVC should be between 8 to 12 millimeters. If IVC is less than 8, patient is severely dehydrated. We can give 400 to 500 ml of IV fluid bolus. We can hydrate the patient at 100, 120 ml per hour as per hydration need or response. If IVC is less than 18 millimeters and if it is collapsing, if the collapsibility is more than 50%, we can definitely hydrate the patient because hydration will improve the hypotension status. It will reduce the tachycardia and it will benefit the metabolic acidemia to sustain all the organs like kidneys, brain, liver, muscles at a better place or at a better shape. If IVC is more than 18 millimeters and if the collapsibility is less than 50%, it means patient is well hydrated and patient may not respond to hydration and the tachycardia hypotension may not improve even with this IV fluids. So if the patient has tachycardia and if the patient is hypotension, then to compensate this hypotension, because as the blood pressure is low, to sustain the cardiac output, heart rate has to increase because blood pressure into heart rate is equal to cardiac output. So if blood pressure falls, heart rate has to be increased so that all the organs do get this perfusion. Other things is whenever there is acidemia, there is markedly increased risk of arrhythmia. So in acidemia, if the patient's pH is less than 7.2, patient has much of chance of getting SVT or VT or VFib. If there is multi-organ dysfunction, then the risk of arrhythmia is much, much higher. That is the reason why acidemia has to be corrected, treated very, very aggressively. We must know that hypotension plus acidemia is very resistant to inotropes or vasopressors. That is the reason if the patient has acidemia and hypotension, they may require a larger dose of NORAD or vasopressin or whatever inotropes we are or vasopressors we are using. If patient doesn't have acidemia, the arteriolar dilatation will not be there, and even with lower dosage of inotropes, even with lower dosage of vasopressors like NORAD, noradrenaline, or vasopressin, blood pressure can be very easily maintained. So acidemia plus hypotension, they usually need higher inotropic or vasopressor support. The most important treatment for this hypertension of acidemia is correction of underlying cause. The most common reason in ICU setting is sepsis. So treating with proper antibiotics, hydration, repetitive doing VBG or ABG is extremely important. Removing the sepsis focus, like treating pneumonias with proper antibiotics, treating abscesses, draining abscesses, treating UTIs, pyelonephritis with proper antibiotic. Without this, treating sepsis, blood pressure will not improve, acidemia will not improve. If there is acute gastroenteritis, giving proper hydration, correcting acidemia is very important. Lower respiratory tract infections or diabetic ketoacidosis in DKA, proper hydration, insulin, giving bicarbonate, correcting potassium phosphate is extremely important. In heart failure, treating heart failure with NIV support or ventilator support with oxygen, with diuretics to reduce the cardiac workload is extremely important. Then only the acidemia will get settled. Poisoning patients, treating poisoning with proper treatment is with proper antidotes or with support treatment is very important. AKI, acute kidney injury, that can be drug induced, that can be uh, UTI induced, that can be hydronephrosis induced, sepsis induced, commonly causes acidemia. So correcting underlying problem will correct AKI and it will correct the acidemia. Urosepsis or any sepsis, treating underlying cause only will definitely make sure that acidemia goes away. We must know that acidemia in long term is very much of catabolic state. So it will, as patient has hypotension, so there will be anaerobic metabolism. So it will cause increase fat loss, protein loss, muscle loss. There will be tachycardia. So this tachycardia again will increase all the glycogen, fat, protein metabolism, and it will again cause fat loss, muscle loss, weight loss, and all the parameters. That is the reason why they need higher protein diet or higher calories per day for recovery. And because of this catabolic state, because of the loss of muscle, patients they significantly get tremors, tremulousness, or pain, reduced capacity of working. So this was all about metabolic acidemia. We'll come with some other interesting topic.